Panel 3 for this afternoon is Transforming Systems of Care, Hospital Systems and FQHCs Leading the Way. It's my pleasure to introduce Pam Belluck, who will be our moderator for this panel. Pam Belluck is an award-winning health and science writer for the New York Times. Her recent honors include sharing a Pulitzer Prize and winning the Nellie Bly Award for Best Front Page Story. She was selected to be a Ferris Professor of Journalism at Princeton University, is a member of the TED Med Editorial Advisory Board, and was awarded a Fulbright Scholarship and a Knight Journalism Fellowship. Her work has been chosen for the Best American Science Writing. Ms. Belluck has spoken in various venues, including universities and medical schools and the National Academy of Sciences. Ms. Belluck served for a decade as a New York Times National Bureau Chief before becoming a health and science writer. She often investigates complex or controversial subjects, including gene editing, reproductive health, infectious disease, and mental illness. In her spare time, Ms. Belluck is a jazz flutist performing regularly in New York City. I think we're in for a treat. Ms. Belluck.
Thank you all so much. Is this a good volume? Can you hear me okay? All right, I'm not going to be playing the flute for you today. Welcome back from lunch or from your breakout sessions. I spend some part of my time writing about maternal mental health. I've been doing that for several years, and I've written also a bit about how pregnancy affects a mother's brain. And I have already learned so much, even given the things that I've been working on for several years. This conference has been so illuminating already, and it's a joy to have been invited by Joy to moderate this panel and to contribute to this really interesting and fascinating event. So this panel is going to focus a little bit on approaches to solutions to some of the problems that we've been hearing about all morning. And I'm going to introduce our four panelists who all have, in some way, are involved in creating and shaping programs that are trying to address the really unmet need of maternal mental illness, and how to fill a lot of the gaps and the breakdowns in the system that you've been hearing about so far today. So I'm going to introduce them, and then we'll have a conversation, and then we'll take some questions. Please feel free to submit as many questions. I guess we'll be doing it that way, as you like. So first, I'm going to introduce Barbara Sheehy. Barbara has spent the majority of her career managing public health and nonprofit programs serving children with special health care needs and their families. In 2013, she began leading collaborative health system improvement projects. And then a few years later, she joined Dignity Health as the Maternal Mental Health Project Manager. And Dignity Health recently merged with the Catholic Health Initiative, and it's now called Common Spirit Health. Barbara received her degree in psychology from the University of Colorado Boulder and her master's in speech pathology from the University of Wisconsin-Madison. Welcome, Barbara. Next, I'm going to introduce Melissa Hanna, who is both has a law degree and a business degree, and she is co-founder and CEO of Mommy. And we're going to hear a lot about that. She's going to tell us about its comprehensive prenatal and postpartum care management platform. It has a staff of trained and certified maternity support professionals, and they are here to deliver education and guidance to new moms and new families. Melissa got her business degree at Claremont Graduate University and her law degree at Southwestern Law School. She has worked in operations and strategy at startups in healthcare, education, digital media, and consumer goods. And she also worked at Columbia Business School. And her MO basically has always been to forge cross-industry collaborations and partnerships to solve big challenges, and she believes very strongly in equitable access to health care for women and children, and that's, I think, what all of us here are hoping to talk about. Sitting next to her is Mona Patel, who is an attending physician in the Department of General Pediatrics at Children's Hospital Los Angeles, and also an assistant professor in the Department of Pediatrics at the Keck School of Medicine at USC. And Dr. Patel is a fellow of the American Academy of Pediatrics and board certified in pediatrics. And in addition, she was named a top doctor by Pasadena Magazine. Now, we heard an incredibly moving story this morning from Stephen DeKilly, I think, you know, all of us were very affected by the story of what happened to your wife. On this panel, Stephen is here to talk about what grew out of that, which is a foundation that he created in the wake of his wife Alexis's passing to increase awareness concerning women's perinatal mental health issues and to improve treatment outcomes for women and their families in the Pittsburgh area, which is where you're from. The foundation, in a partnership with Highmark Health and Allegheny Health Network, recently opened the Alexis Joy DeKilly Center for Perinatal Mental Health in Pittsburgh. This is a 2.5,7,300 square foot state-of-the-art facility offering women and their families access to a broad spectrum of treatment options. And Stephen is also active with many other women's mental health organizations and sits on the board of Postpartum Support International, and also with his family owns and operates the Pizza Roma and Pomodoro Italian restaurants in Pittsburgh. All right. Do they deliver to LA? Okay. All right. I would like to start with Melissa, sitting here directly to my right. Melissa, could you tell us, grab a mic. Tell us a bit about Mommy. I'm interested in hearing what problem you were seeking to address when you established Mommy and how it works, and you know, just sort of a little bit about your startup journey there.
Hi. Okay. This absolutely has been a journey to, and one that's been mostly uphill, to build a comprehensive prenatal and postpartum care platform that is really crossing over between the tech industry and Silicon Valley, sort of in quotes, and the healthcare industry, where we really want this to be focused, but where it also has to fit into the technology components of healthcare. We initially tried to solve for what is clearly one big part of the broken system of maternal infant healthcare, which is the lack of unified IT infrastructure for being able to rapidly and effectively communicate with multiple providers who are supporting the same patient. We know that in maternal infant healthcare, we've got it's not just the OB and the pediatrician. There are a lot of other support professionals, ancillary care providers, and community-based organizations that can and are often a part of the patient's care experience. How do you effectively communicate what's going on with the mother-baby dyad at any moment in time when you've got professionals that are all using different tools in different buildings, and sometimes in different cities or counties, and in some cases still using paper charts to document their observations, especially in the home health setting? So we thought that this might initially be a software challenge. We went ahead and we started building the software that would allow for all of those providers to connect up, and for those folks that are still using paper charts to, in time, move online and go digital with their own charting and documentation and communication between patients and also with their fellow providers. We started taking that to systems, which is what this panel is about, and taking it to FQHCs, taking it to multi-facility hospital and health systems, and saying, hey, look, we made software. You should be able to now talk to anyone else who's taking care of your patient once they leave this building. And behind closed doors, C-suite executives kept telling me, okay, but who's going to actually do the work? We don't have enough people here to support every mother coming out of this building. We don't want people to know that. We've got programs, but we don't necessarily have the operational capacity to make sure everyone can participate in these programs. And that began the second part of this journey, which was to not just build a software company, but to build a software plus services company that would staff up, as Pam said, with the professionals that would allow these organizations to extend their capacity and to provide more comprehensive support and care coordination to every person who needs that, not just the folks that we think need it in that moment or look like they need it, or, oh, something on your chart tells me you might need it, but actually understanding that risk, whether it's related to clinical, obstetric risk, pediatric risk, mental health risk, all of these things are constantly varying over time. So we've got to be there to catch people before they fall. So that's what Mommy does, and we partner with organizations, including Ultimate on the panel today, to do that work.
Well, I'd like to hear from Dr. Patel about how your experience using Mommy. How did you end up deciding to use it, and how has it worked for you? What are you actually doing with it?
So just to give a little bit of background, kind of our healthcare system. So I'm a practicing pediatrician. I'm vice president of ambulatory operations for Children's Hospital Los Angeles, and we're aligned with Ultimate, which is a federally qualified health center. And what that means is that we serve a predominantly underserved population. So 92% of our catchment sort of group of children that we care for are in underserved regions of Los Angeles, Orange County, and beyond. Years ago, when I first met with Linda, Melissa, everybody, I think as a pediatrician, we know that in order to optimize the health and well-being of a child, an infant, a neonate, I need to make sure that mother, family, unit, dyad, social supports, everything is intact, right? And I think it's that upstream view that we've always taken. Realistically, my OB colleagues, when you give birth, OB is not seeing women usually until 6 weeks postpartum. I'm the one that's actually seeing the mothers. And it's sort of that advocacy and that push to say, well, I should be paying attention, I should be screening for depression, I should be looking at what are the supports, because ultimately I need to make sure the care and well-being of that child is made whole. And I know nutrition and growth and everything is going to be wholly impacted by mothers' mental health and support systems. So we started screening. We started doing all types of screening. We see babies usually 24 hours to 2 days after birth. We've built a program within our FQHC medical home with lactation, with social work, with kind of wraparound services based on our screenings, and really training our pediatricians, our residents, and our future sort of physicians in taking the time to ask the questions, looking at parents in the eye. One thing that I'll say when I teach my residents, that first visit, I know that child's life is going to be my job as a pediatrician, but when I walk into the room, I make sure that the mother is comfortable. Is she the one sitting down? I'm going to take care of that baby in a minute, but I need to make sure, and I ask those questions. How are you doing? How are you feeling? Are you engorged? Are you having pain? And I focus, who's supporting you at home? And I found when I started doing that, and I'll admit I started doing that after I had my own children, and I realized what it's like. Deep respect. About 50 to 60% of the women just started crying, just because I asked that question. And I got so many overwhelming emotions, and that's when I started realizing how important it is in my job as a physician and a pediatrician to ask those questions. And then along comes the team with Mommy and saying, beyond that, how do we support and integrate the extension of mental health services and screening? And in our program actually budded from home phototherapy, understanding that when women are discharged from the hospital, the last place you want to go with your baby who has elevated bilirubin is back in the hospital. We want to be in the home environment. And then working with our team, now that we're dispatching home care and lactation services in the home environment and doing screening, we started realizing with our population, We have families living in cars. We have families living in garages. We were able to, I think I shudder when Linda calls me directly, and that's a phone call I answer right away, because it's sort of like I get palpitations like something's wrong. She's calling me personally right now. We had an incident that you called me about. We were worried about domestic violence. And these are things that we are able to step in with our team of social workers, and that constant following up, constant contact, and working with sort of that extension care. I think those have been the biggest lessons learned.
Thank you. Barbara, so you have a digital approach as well, right? You guys have developed an app. Can you talk about that, and also anything around that you feel is relevant about your approach to maternal mental illness? I think you were pretty early in getting something established to directly confront this issue, right?
Yes. So in 2016, our Dignity Health leadership, including our philanthropic leadership, selected maternal mental health as a priority patient care initiative. And at that time, we had 29 birthing hospitals across California, Nevada, and Arizona, with about 60,000 births a year. Since then, with this recent merge in 2019, we have maternity hospitals across 13 states, so 65 hospitals, and we're actually going to be have the privilege of having 1 in 40 babies born in the United States born in our hospitals. So part of what clearly drove the interest is the sheer number of women and families we have an opportunity to impact. And yes, one of the things our leadership was interested in at the start was any kind of opportunity for using digital solutions to support as we started looking at providing patient education, screening, and so forth. Also in 2016, we were launching a pregnancy journey app called My Baby. It's available to anyone. And one of the things we did initially was we made sure that we were inserting emotional wellness, mental health content into that app. And then gradually we were able to add the Edinburgh Postnatal Depression Scale for a woman to self-administer. I'm really appreciating this conference and then this panel, hearing about the ways to go beyond to really get more of that interconnectivity.
Okay, great, and we're going to talk a little bit more about that too. Stephen, so you have sort of this bricks and mortar approach, which I think is pretty new, right? Is it like a year or two old?
We had a temporary facility for 3 years in the hospital that started with one space, and then it grew so quickly we had 3 different spots in the hospital. Women would start here, then move to the 2nd floor, the 3rd floor, because our project kept getting delayed, because as my perspective would change and I would learn more and the doctors would learn more, we kept expanding the program. So it took about 2.5 years, and but we opened in December 2018.
So tell us how it works. I think there aren't that many freestanding, kind of maternal mental health units in hospitals or centers. So what does a woman have access to? What types of patients are you seeing? How do they get referred?
Sure. So my wife's problem was, if you look at all her screenings, it's horrific what she was writing down and how she was answering questions. And when a mother screens positive, where does she go for help? And that lack of access kind of became my passion, and decided to build the center that I believe would have saved my life, or saved my wife's life, if she had access to it. And we take a family-based approach where we invite not just mom, but her baby, her partner, and also any other children she might have at home, and include all of them in the program. And we offer, meditation, yoga, mindfulness. We have a chef's demo kitchen where we teach women how to eat healthy foods and prepare them and encourage their husband to participate. So if nothing else, he can cook dinner and take something off her plate when she gets home. And they also leave with a box full of all the ingredients so they can take that home and prepare those meals. We have lactation consultants there. We have quiet areas where mom can just kind of nod off and get some sleep if she needs it. We have individual therapy as well as group therapy. We have. It's really amazing how comprehensive the program is, and we truly try to encourage the whole family to participate, because I feel, as a man, and I'm usually the only man or one of few in the room, I think there is we always talk about motherhood, but fathers get left out, and I don't think it's because they want to be. I just think that's, for generations, that's how it's been. And I always say, men become dads the day their baby comes home from the hospital. Women become mothers the day they get pregnant.
So it's inpatient for the mom? And
It's not inpatient.
Not inpatient, okay.
It's a 3-hour, twice a day, intensive outpatient program. And we treated 3,000 women last year in Pittsburgh. And we also, if you screen positive, we're trying to get under 24 hours to see a perinatal mental health specialist, but we're under 48 hours, which is, I'm proud of that.
That's great. I'd like to ask you all, maybe we can even just go down the line, Stephen, if you want to start, just, anything else you can say about the results that you've seen? It's a little early for your program, but I mean, in addition to 3,000 women is a lot. Are you measuring this in any way? Is there a way that you've been able to do follow-up on these
So for
patients?
me, I'm not a doctor. I'm an advocate and a fundraiser, and so I raise money to make sure that moms and families get the best experience possible. But I think with our program, one of the unique things is baby can participate. And we took a very direct approach, saying, what are the barriers to care? What prevented you and your wife, myself and my wife, from getting the care we needed? And then also, as we learned, and the big thing was, it's hard for moms to get to the hospital. So we offer free transportation to and from the facility, as well as childcare for all of the children that mom might have at home. And so I think the healthcare experts would say that the number one demographic for people that miss doctor's appointments is mothers, because they're busy. But guess what happens if mom can bring her children? They don't miss their appointments. And so, we offered free transportation to and from, as well as childcare, and that's been amazing.
Great. Barbara, do you want to talk about the results that you've seen? And each of you, too, if there's an example that you'd like to share, that sort of, a story of a particular patient that would kind of illustrate this, I think that might be powerful too.
So one of the main things that we did in 2017 is, after surveying our hospitals, we first piloted and then began screening universally all women who give birth at our hospitals prior to discharge. So each woman gets some education, she's screened, and based on her score is referred to social services as needed for further assessment and follow-up. And so we've screened over 127,000 women since mid-2017. And one of the things I'll say, that with our implementation, it's our staff, our hospital staff, who have taken this on, and they really embraced this work. A lot of the nursing and social work staff were actually, in spite of the fact that it was additional work, they were really pleased to do it. We also began providing in-person training across California, Arizona, and Nevada for our staff and providers, but also for the community. So free trainings, we partnered with Maternal Mental Health Now and had excellent feedback on those trainings that lasted from 2 hours for our providers to 2 days for other clinicians and such. So we trained over 1,100 clinicians and community partners. Then the other things that we are doing in addition to really trying to enhance education of our patients, our staff, and the community, as well as screening, is we're piloting various ways of providing intervention. And our hope really is to catalyze change, so to pilot something sometimes in partnership with others in the community. So in California, we're now providing a perinatal psychiatry consultation service so that any provider in California can call a perinatal psychiatrist Monday through Friday in the afternoon and in real time get a curbside consultation. So this is one example of ways that we're trying to support our providers to really build their capacity to better identify, diagnose, and then treat women, sometimes until they can get additional care. As we've all talked about, the challenges of getting appropriate and timely care, whether it's for psychotherapy or for psychiatric care, is very challenging. And then other things we're doing, we're offering, again, free to community and staff, intensive facilitation training to try and catalyze, support more groups for pregnant women, postpartum women, but also some specific groups. So it might be groups for dads or parents who have kids in the NICU. We know that there's a lot of sort of subpopulations that all fit into this desire to better support perinatal women, infants, and families.
That sounds really, really important. Mona, you were giving some kind of compelling descriptions of where you find your patients and where they end up. Can you think of a story or two about a specific woman who was helped through this outreach that might have otherwise fallen through the cracks?
Oh, sorry, so many. One specific one that comes to mind is baby that was born at 40 weeks and was actually in the NICU for feeding and growing, discharged, and was seen by one of our pediatricians a couple days post-discharge. And we did our screenings, everything was reported okay. Baby was dropping a little bit of weight, which is normal right after birth. And mother seemed very supportive, family was engaged, father was at the visit. I think maternal grandmother was there, flew in to help the family for the first couple weeks, and then did a follow-up visit a week later to check baby's weight and see how child is doing, and noticed that the baby dropped a little bit of weight, started asking about kind of lactation and breastfeeding. Mom reported that she was engorged, having a lot of nipple tenderness, so had mastitis, which means she had fever, starting to struggle. Grandma actually had to leave early, and then father was working nights and taking care of disabled parents who moved back into the household. The way that we saw it as pediatricians in our clinics is baby kept dropping weight. We would say, okay, then come back in 2 days. Still screen and kept scoring okay on the screens, right? We did the PH2, we did the Edinburgh, but we weren't catching it. So based on the weight, kept probing and asking more questions, and that's how we got all these stories of the actual lack of support system that started to evolve. We were able to get social work to jump in. Also found mom was in a place where she's the only one who had children and lost contact with her friends. and was in this environment of isolation at home. And having close contact with our social workers, we're able to kind of wrap in a little bit of CBT and whatnot and start building up a social support system, getting mom to kind of start doing meditation and yoga. Working with father, had him come into the visits, and then we naturally, and doing a lot of support for lactation, started seeing baby's weight start to rise. So it's so complicated because we can do a lot of screenings. We can kind of say, okay, fine, this child or family is doing okay and we don't need it, but I think it needs that extra level of constant asking the questions. And it's that constant follow-up, and that's how we started seeing it manifesting. Since then, we've grown to not just screening, but thoughtfully asking the questions over and over, closely following and seeing what's going on with the dyad and the whole family unit. And collaborating with a lot of neighborhood partnerships and bringing in mental health services because our need is extraordinary. And there's a profound lack of mental health resources, so we're looking at virtual options, we're looking at home mental health visits, we're looking at working with mommy. We have to be so nimble in so many different avenues to touch our families, because the other reality we face is reimbursement and cost and what it takes, so you have to have multiple different programs to be able to touch the population.
And that kind of perfectly brings us to the need that you're filling. I think when we were touching base on the phone before this event, you had a very compelling story about what your platform was able to recognize. Can you talk about that?
Yeah, actually, I was thinking about that story, and I was also reminded of another related to weight. So I'll share just two little vignettes about what care coordination in the digital age can look like through a platform like Mommy or others that are doing this kind of work, either clinically in maternity and in pediatrics or specifically within mental health and emotional wellness. The first story that Pam that you're referencing. We can deploy Edinburgh screenings through the platform. Those can be programmed to go automatically out to patients at certain periods, at certain points in time, or it can be manually deployed by a provider saying, "I'd like to have this patient self-screen." In this case, a pediatrician had onboarded a new patient to the practice with a 14-day-old. And at that marker, she received a 14-day postpartum check-in, including an Edinburgh screening. She scored 21 out of 30, so in a very high-risk zone. That immediately flags in the Mommy platform. Our care managers, it's like red lights and bells go off right away for someone to be immediately in touch with the patient. The clinical protocol that we follow is to verify the reported results. So that includes a phone call to that patient immediately. On her end of that screening also, she received her score, some education, and sort of a message of like, hang tight, we're gonna be in touch. And so got a call on her cell phone, spoke on the phone, and ended up crying on the phone with the care manager and saying, I just don't feel like myself, and everyone else is saying I'm doing really well. She was not otherwise scheduled to see her OB/GYN for another 4 weeks. So we've got now a case, and this was actually through our partnership with UCLA Health System. So we've got a great health system here with a lot of resources internally and psychiatric and psychological supports in place. But this patient is otherwise falling through the cracks because she looks great on paper. So in that. It was if 10 minutes phone conversation. It really is, our protocol is to verify the symptoms and then immediately flag and escalate that patient back to primary care. Now, mind you, she was onboarded by her pediatrician. Her OB/GYN was not a member of Mommy, hadn't actually activated a practitioner account through Mommy, but we know who her OB/GYN is because she's part of this health system partnership. And so our response then is to call the OB/GYN. This was after hours, so we're talking to someone on the after hours physician line, relaying what's going on, coordinating care, basically figuring out what the next course of care is. And mom is saying things like, I had this crazy thought, like maybe I should leave the baby with my husband and walk into oncoming traffic. And I'm saying, I know that that's not right. And my friends told me I was going to feel a little weird after I had the baby, but is this what they were talking about? So you hear all these bits and pieces of stories we've all heard. And so to bring that together now, we've got physician on the other end, facilitating care and dictating, okay, we're going to get this patient in 9 a.m. the next morning. unless patient needs inpatient service tonight, unless we're going to facilitate a readmission, in which case that's not what happened here. This patient was able to be supported at home, receive overnight support through the platform, and then was on the calendar 9 a.m. the next morning to see her OB, who then communicated back through mommy and said, I had no idea, thank you so much for bringing this to my attention, which is usually what ends up happening when a case like this occurs, is that physicians want to know but don't otherwise know. Just a quick thing on baby weight and just the flip side of it. We had a pediatrician contact and actually add a mom. So the majority of our patients are onboarded by a primary care provider. Someone who's saying to them, I go home at 5 p.m., but these people are open all night. Really nice pitch, right, from the doctor to the patient. So you've got a pediatrician here, contacts us, onboards a patient and says, I needed to keep an eye on the baby. This baby's been gaining a lot of weight lately. Baby was in the 50th percentile, looking real good. Next week was in the 60th. Okay, now they're in the 75th. And actually, baby just came in yesterday at 90th percentile. I keep checking with mom, and she's like, everything's great. I'm breastfeeding like a champ. Now, the pediatrician knew just enough to say that something's not quite right, but not necessarily to figure out where to go from there. As it turned out, through conversations and inviting this mom into a digital support group with other mothers with babies of the same age, she revealed that she was experiencing severe anxiety living in her apartment building, where another mother in the last year had been yelled at by neighbors for having a crying, screaming baby. So what do you do when you're crying, baby's crying and screaming? You feed your baby. Now we've got a baby in the 90th percentile. So, right, the flip side of this, but these are the stories that when you kind of pull back the curtain, you figure out that there actually is often another dynamic going on that may be affected by mental health.
Oh, those are both really amazing stories. One of the things, I mean, I don't have to tell any of you in the audience, but one of the things that always, kind of fascinates me about this area and what makes it so challenging is that it is so individualized, and as I think Mona, you were suggesting, you can develop something at any point in the perinatal period, and if you're not caught at the 6-week OB visit or the 2-month pediatrician visit, that doesn't mean that you're going to end up not having an issue at 4 months. So you're dealing with a very rapid, very fluid and unpredictable situation with a lot of different inputs at different times, in the mother's experience. I think there are going to be a lot of people in the audience who are going to want to learn about how they might try to emulate some of the programs that you have, and so I always like to ask people for a challenge that has come up that made you have to change something. We've talked about the features. Tell me about a bug that came up and that you had to swoop in and say, no, we can't be doing it that way. We've got to be doing it this way.
I think for us, it was what makes our program special is that it's a very patient-forward approach. And even though I don't work in healthcare, we kind of we did a vision board like early on, and it was what were the obstacles we faced and what would the dream scenario be like. And I was very adamant, and the health system was very understanding that of certain things that were important to me, like I'm a restaurant guy, I like to cook, and I wanted I wanted a demo kitchen in it. And so it was practical, everyday solutions to problems. And I found that oftentimes things get really confusing, and usually when it's confusing, it's because there's just a bunch of BS mixed in. There's really practical, simple solutions to problems, like solutions or like transportation and childcare, if you get creative. So I'm not a doctor. So I just try to figure out what problems I have or other people that I know hearing stories like this and try to think of simple solutions for those problems.
A couple of examples. I think when it comes to trying to introduce new interventions or support ongoing ones, I think an example with the perinatal psychiatry consultation service. So we modeled that service after the McPat for Moms program out of Massachusetts, the consultation component so far, and it took a good 18 months to, keep after getting everything in place to actually be able to offer that service. So it took a lot of time and persistence to get it through legal and so forth. And then once we launched, what we are finding, and this is what we hear from others across the country that are doing similar programs, it takes a lot of effort to engage providers in using the service. So the idea that you build something and they will come is not, in fact, necessarily the case. In a similar way, we launched in the north part of California a maternal mental health telehealth service where women can access psychotherapy online. We have a nice setup, so basically their insurance could be billed, and if not, it would be covered. We had an outside grant for this. And the same thing, while it only started in September, we're having to work very hard to engage the community and providers in making use of the service. So the whole outreach and marketing and having people come to trust a service, I think, is really important.
So how are you doing that? I mean, are you going out, practice by practice?
Yeah.
Are you making lots of phone calls? Are you, billboards? I don't know.
Yeah. So using the consultation service as an example, this is also where, learning from small Massachusetts how to do something in great big California, it's going to be a little different. In that case, we are offering to have our perinatal psychiatrist actually go do grand rounds, remotely join a staff meeting of OBs or pediatricians, just to share a little bit about how the service works and so forth, and then promoting it through organizations like ACOG and Academy of Pediatrics and so forth.
Mona, do you have a problem that came up or a challenge that you...
I feel like I live in the world of challenge. Just because you have to take a patient-centered approach, right? It's easy, I think, as physicians and health systems to prescribe and think that we know best and we're gonna decide and we're gonna implement. But gosh, you just get kicked down every single time. We had physicians that said, I'm gonna start prenatal classes and I'm gonna educate and I'm gonna teach the residents and I'm gonna do this and I'm gonna make it Monday afternoon. And then you go months and nobody shows up. And then you realize, well, how come nobody show up? I have a doctor sitting here and then, okay, what if we engage with WIC? What if we do this service in the community? What if we do it in the evenings? What if we offer childcare? And you start seeing all these iterations and finally the population starts to engage, right? So you have to be patient-centered, and we've gotten our butt kicked constantly and continue to do so. I think understanding the different challenges with different patient populations. So in my new role as VP, my commercial lives have very different challenges in access to behavioral mental health services, quite frankly, from a payer perspective. My underserved populations have rampant changes in legislation constantly with coverage and reimbursement modeling. So it's being nimble and seeing, but I think the most important thing with this topic and integrating social emotional determinants of health and upstream is to always work towards that North Star and that vision, and you continue to persevere and say that it has to be built with an equity lens. It has to be prioritizing the health and well-being of our populations, and you kind of have to be scrappy and change your system based on your patients.
Melissa, do you have an example like that too, or something?
Yeah, I would say a lesson absolutely from this. So this is where being a technology company and having an in-house development team has informed a lot of the way that we actually do this work of transforming systems of care. So in our development practice, we approach things from a very agile methodology or standpoint. It's something we're constantly iterating on what we're building and testing and looking at data. So it's a very data-centric approach to say, okay, what's working? And data doesn't have to be a very highbrow concept here. The fact that no one showed up for prenatal classes on day one, that's data. You had 0, and so really going from that point and saying, okay, well, we know that our hearts are in the right place. We know we are trying to do the right thing, but here's the result we're getting. How do we, how do we really build on that from that number 0 and getting it to 1 and above? What I would say is sort of the bug in doing this work that we are constantly fighting against is, and this is sort of a weird intersection we're at right now. It's not going to be this way forever in this industry. But I go into a lot of spaces where health system leadership say, yes, we want this. We want help. We are so committed to doing this work. But do you guys integrate? So I hear this I word, integration. Now, maybe you've heard some of this in some of your work, right? That's not the I word that matters. It is not about integration. I can tell you why in a second, but I'll tell you what it's really about. It's about implementation. It's about how do you get this work out into the community, out into the patient's hands, out into the provider's hands, and that is where all the bugs really are. Integration is actually pretty easy, and I'll tell you the secret, most tech companies can do it. If you want to work with them, if you want to bring that tech solution into your organization, that's not going to be where the challenge is, because if they've got developers, they can figure out how to connect up to whatever you guys are using. The hard part is making it possible for everyone else to use the thing that you've built. And so for us, literally, we have to go around the community when we do a rollout or an implementation. We have folks that are called community partnership coordinators. They go to your practice. They go to your home. They go to your community center. They go to your WIC center. They figure out how to make it possible for you to onboard into mommy, to use mommy, to make mommy work for you, whether you're a patient or a provider. It always is going to come down to that, that challenge of how do you roll this out in this particular city, this region, this county, this state. The funny thing about integration, actually, Ultimed is a great example here because, well, no, we had the benefit of working with Ultimed early on in their own transformation process. As many parts of the organization were going toward digital solutions, and Dr. Patel was leading all of this. So imagine sitting down and saying, we've got software. We want to connect our software up to your software. We can integrate. And then hearing,
We're changing the entire EHR.
not yet. They changed the entire EHR in the middle of us already working with Ultimed. What we found was that integration can sometimes mean we've got a PDF here, it's secure, it's encrypted, we're going to send it to you, and then you can de-encrypt it and bring it into your system on your end. Or we're going to fax it, if that's what it takes. Because some tech companies, like ours, still fax. Because our customers still fax. So that's really what it comes down to. I think that it's very important that we start to pull back that curtain on what this work really looks like on the ground.
All right, should we take some questions? Are there some out there?
My name's John. I'm a pediatrician, and I help innovators across the country at all levels of healthcare, government payers, policymakers, health systems, tech companies, integrate and implement in a financially sustainable way and scale what they do. So the first thing I want to say, Stephen, first of all, thank you for sharing your story. It brought up painful memories, actually. About a year ago, I met a father who had had a loss. When we, at the Center for Youth Wellness at the time I was there, wanted to study childhood trauma and how it leads to violence, particularly intimate partner violence. And he started a foundation called the Aviel Foundation. You may have heard of this story. And after I met this gentleman, who everybody described as the ultimate collaborator, integrator, brought everybody together, he had lost his daughter, I believe, in Sandy Hook. And that's why he created the foundation. And a few months after we submitted a grant to do this research for his foundation, he took his own life. And so I think just a comment on this, it's very, very important that as we do this difficult work, we are all thinking about how we're supporting each other and ourselves and not just the mothers. You look like you're doing great with self-care, so not specifically, but I think it's a very, very powerful anecdote and really touched my life. And he was an incredible man, but you know, we can sublime what happens to us in life but things do linger, and for all of us, really, I'm speaking about myself, it's very important to take care of ourselves and each other. And by way of that, so I love to help people scale what works, no matter how complicated. Those who know me, I don't shy away from anything complex, so you need any help with that, how to grow it, I'll be there for you, okay? Thank you for what you've done. My question to all of you is, so as part of all the work that I do, I get to advise some folks who may have some influence. We've heard a lot about the payment at the Federal Centers for Medicare and Medicaid Services around maternal infant health care quality and innovation. I'm blessed to advise them in the state of California. So if you had one thing, just one thing that policy or payment could change to just flip the switch and would make a huge difference for those that you serve or your innovative models, open to any of you, what would it be? And I literally will relay this, so have at it.
First and foremost, I think equitable reimbursement for the actual work it takes to take care of the population. And what I mean by that is not, right, that's just like big scale, I'll go right there. Not just fee for service, not just the physician fee, but the social work, the nutrition, the mental health wraparound, everything, so that the collective reimbursement actually reimburses what it takes to take care of an individual, family, and support system.
I take a different approach to things, but I think the one thing that's made our program so successful is storytelling, because we've been able to give a voice to people that otherwise would not have one. We did a campaign, it's a green couch. I don't know if some of you have seen the commercials, but women's health was the big initiative within the health network. In the first year, they wanted to highlight our program, but they weren't sure how to do it. And so there's a commercial of me pushing my daughter, and it was 30 commercials in 30 days, 15-second spots, of all the things the health network was most proud of. And that went from doctors to nurses to patient stories to different advocates. And of all these amazing things going on in the health network, when you talked about maternal mental health with our commercial was more successful both on TV and social media and every way you can gauge it than all the other 29 put together. So and it showed people care. And helping moms is helping families. And the second year, I said, how are you going to highlight our program again? And the couch was for women only. And it was always one woman talking with another woman. It was a woman that was going, maybe, say, cancer. It was a woman that survived talking to someone that was currently in treatment. And they would just capture these amazing conversations and highlight certain parts of it in the commercial. And I said, they kept filming two women, one that was better and one that was still going through, but the message wasn't right. And I said, well, you need to put a husband on with a man on with one of these women. And they called 2 months later and said, we want you to be the guy. And so I'm sitting on the couch, on this women's iconic green couch, and we're midway through and everyone in Pittsburgh knows not everyone, but a lot of people know the story. And the woman says, oh my God, you're Alexis's husband. And it was 4 hours of shooting, but there was this amazingly powerful commercial that came out of it. And they did like a 2-minute piece, 1:45, and it was so well received. Again, of all the 30 different initiatives, maternal mental health was #1. This past year, we're trying to find a bigger voice, so we were able to get Chrissy Teigen to come and say, there needs to be centers like this in every city in America. And so we launched the My Wish for Moms campaign, and we had 16 million people participate worldwide from 116 countries. I think there's like 186 countries in the world. And it was really unbelievable. And so I really think something that's really overlooked is the power of storytelling. And that has really driven this program from day one.
Good afternoon. Can you please speak more about the community partnerships and community engagement connected to language access? I'm curious from the beginning in terms of outreach and then also to utilization, how the systems capture, perhaps, let's say, a need for Tagalog-speaking communities to then access services. So not just translated materials, but also what is in place, trying to connect it to if there's an underutilization of services, how to connect that need and how everyone can help. I don't know if that is clear.
I'll just say, in the hospital setting, what we do is, in fact, make sure that our screening tool is available in any language that is spoken. If we get a call from a hospital, at this point, I think we have the Edinburgh Postnatal Depression Scale and our patient education information in 13 languages, in terms of assuring that there's appropriate, linguistically and culturally appropriate care in the community. We're certainly not there.
In designing, actually, it comes back to implementation, but in designing a rollout of a program in a community, culturally competent care is an important pillar of designing the implementation process. And what I mean by that is that as you are, whether it's physically or sort of digitally rolling out a program across a region, part of that work includes understanding who's in that community and what sort of resources, digital or physical, like whether there are literally centers that people go to, whether those are nail salons or hair salons or supermarkets. There are different spaces within any given community that become hubs for information, for support, for social and emotional support that have to be incorporated into that strategy. So going beyond just translated materials really includes understanding who and what are the pillars of that particular community that are going to be the touch points for successful implementation. And that's one way to think about cultural competence, is that you're not always the one who's interfacing with that patient. So you have to figure out who else is and how you can support that person.
What are the barriers to integrating the two-generation approach in pediatric hospitals, and what's the first step to dismantle the barriers? I think this was meant for Dr. Patel.
Barriers, I hate to keep coming back to reimbursement and those issues, but it's a reality. I can say that within the Medicaid system, we can do it. We have been doing it for many, many years, caring for the mother-infant dyad. It's actually Dr. Goldfinger who started working with us many, many years ago in helping establish kind of those rules and constructs and all of that. I will say, again, going along with that kind of vision and equity, we provide the services, regardless of payer. Okay? While we're on the back end advocating, we're working with legislation, we are working with the health plan, we're going through contracting, and we have teams looking at that. The care I will, and I'm most proud of, is equitable, in that if we can't get reimbursed, we're still going to do it. Don't tell the C-suite that, because that's important, right? And it's now, okay, we're still going to provide the service, but now how can we go to the plans? How can we go to the payers? And how are we going to justify all of this? And how can we look at innovation and extend care? But it is a challenge. It is a challenge. And I think it's thinking out of the box also in convincing my colleagues and everybody else that it's important to provide the care for the mothers, the fathers, and everybody else in pediatrics, because it's not just about the child, because of the overwhelming impact that family has.
Hi, my name is Amy. I'm a pediatric occupational therapist in a NICU, and thank you for all your information. I'm just curious, in all your work in the larger systems, if you have any thoughts on how practitioners could do some creative collaboration. I feel like a lot of us are kind of out there all with the same good mission and kind of reinventing the wheel. And, you know, we've talked about piloting different things like bringing social workers into the NICU or bringing occupational therapists into the pediatrician's office. Or I'm just curious if you've found anything that has worked.
I would say for our work originally with Dignity Health and now Common Spirit Health, this is part of our process. Our planning committee looks at opportunities to pilot, improve access to care for women. And I think there's a lot more that can be done. I'm thinking to the earlier question about, one thing that we'd like to do different. I think having more, for example, social work support in a hospital and also in outpatient settings, very often, as has been brought up before, there are fantastic services and resources in a community, but it can be very hard to know about those, keep up with what's current. That's definitely true in a hospital setting where people are so pressed for time. So I do think an investment in a person whose role it is to really be hearing and interacting directly with the patient, and then really knowing what's available, having relationships with people in the community to tap into all the different types of sort of modalities for care and support. So I think having that role, a navigator sort of role, it would be a big help to make better use of services.
I think the eternal optimist and dreamer side of me gets excited because I think in healthcare we work in a lot of silos, but there's a lot of people engaged in the mission doing that work in silos, right? And it's about how do we break down those barriers and have that conversation about how to collaborate. So I'm going to give a shout out to Apple, okay? She came to my office. Gosh, what, a year ago? And started planning and saying, I am seeing these babies, and we're doing dysphagia, and we're doing X, Y, and Z, and how can we work with lactation? How can we work within the primary care environment and collaborate and do this work together? Because we're doing it here on this side, we're doing it here in pulmonary, we're doing it in NICU, we're doing it, and it makes sense because we're doing the same work together, right? Same conversations with social work, with nutrition, with physical therapy, with our nurses, and everybody at our hospital. We've started a formal new committee. Well, there's collaboration and advocacy on stronger, bigger platforms, but we've now started a social emotional determinants of health committee, which has 6 different sectors: behavioral mental health services, 1, food, school systems, homelessness, kind of the whole gamut. And I'm so proud that it's one of the things I co-chair at our enterprise, but I have representation from everywhere. And it's so exciting because you have that like-mindedness in all different professions, and you realize, gosh, you can take care of this, we can do this, and you're stronger together to do it. And then the resources come out of the woodworks, and then you start seeing how can you innovate and how can you get the work done for the population holistically. So I think it's about breaking down those silos and agreeing that we can actually do the work together, because a lot of us want to do the work.
Hi, I'm very much enjoying this presentation. I'm actually a new mom myself, so I just had a baby mid last year, so a lot of this hits home really hard for me. And I work for a tech company down in San Diego, and what I wanted to know is what you think employers can do to better support mothers. I mean, as a company, we provide pretty rich health insurance and leave benefits, but I know that's not available to everyone at large. So if there's things that you think that can be done that may not necessarily be tied to that, is it better contact with the family while they're out, say on maternity leave? What is it that we can do to help support moms a little bit better?
That is a great question, and I think it's a complicated answer because we talk about finding ways for employers to support new and expecting families in and outside of the workplace, and even just to the idea of communication from the employer to the employee on maternity leave. I mean, how many people want to be in touch with your work team when you're on maternity leave, or your supervisor on a regular basis because they're part of your maternal mental health program? So right, that's maybe not what everyone's actually looking for, but there are ways for employers to institute these programs, and there are a number of new tech platforms that are doing this work specifically within the employer space, and I think that's really exciting. What I'm particularly passionate about and cognizant of in that conversation about maternity from a as a clinical experience, as a psychosocial experience, as a physiological and emotional experience, all of these different aspects of maternity, the employer model doesn't necessarily support or have the the support components it needs to touch on all of those areas. And so that's something to be mindful of, is that in order to really provide a comprehensive solution, you've got to balance what can be done from, frankly, like employee benefits or employee perks program standpoint with what the health system is in a position to provide and mandated to provide. So that's sort of an overarching way to think about it, is that I don't think that we should be expecting employers to actually do all of this work, in that, not to say that employers should not fund this. Absolutely, more work needs to be done on the maternity experience for employees. Sorry, this is how complicated this is, right? Like, we want benefits, we want leave, we want paid leave, and we want support for people in the workplace. We also need to make sure that we are not passing this over to employers and expecting that the clinical services and clinical supports and social and community-based supports that are integral to a comprehensive maternal and infant care program are going to be provided by that employer. Because oftentimes the employer is not going to connect you to your local WIC center. They're not going to say, oh, you know that there's Postpartum Support International. They're going to say, here's an app. And hopefully within that solution you have what you need there. But I think this is the stuff, you can see I wrestle with this, because I'm always looking for that right balance. And our product fits into the healthcare stack for a reason, because that is where value-based care programs are going to come from the outcomes that are related to this work on the clinical model. When we can show that this work actually changes the risk model, it changes the cost of care, value-based care becomes a reality for everyone.
But I think, for first and foremost, my job is to make sure that our population is informed of the legal constructs that are in place, right? Legislation that you have certain time, you have certain areas that are supposed to be provided to pump. You're supposed to have all of these things. One of the things that I personally do for my patients is my 1 month visit. I know it's going to sound crazy, but my 1 month visit is, how do I get mom back to being a woman? Kind of thing. And I ask about, sexual protection. I talk about going back to school, going back to work, and I start coaching on, okay, we're going to pump, we're going to store. What's your plan? Have you talked to your employer? What are we going to do about breastfeeding? What are we not going to do? What are we going to do about childcare? And I make it part of my plan, because if I don't do that, I find that once FMLA is done and all of the other things are done, I have patients coming back at my 2-month visit, 4-month visit, and we don't have a plan in place. For me, breastfeeding is really important, and breastfeeding stops, and kind of all of those things. So I make it part of my visit to talk about it and to coach about what are the legalities, what should happen in school, what should happen in your workplace, what can I do as your provider for your child to help support? Should I write a letter? What can I do to help you?
All right. Well, I think we are out of time. Obviously, you've heard a lot of really great ideas and great programs here, and there's still a lot of work to be done. I know some of these questions might be also tackled by 2020 Mom is having a webinar series. We don't know exactly the dates, right, but they're coming, on hospital programs, covering, some more of this material in more detail, and that should be very instructive. I just want to thank all of our panelists and all of you for great questions, and I think we're going to take a 15-minute break.
We have a break. Yeah, we want to also just say thank you to you too, Pam.